Good evening, doctors. I am Dr. Namra Sheikh, Medical Advisor with Emcure Pharmaceuticals. A very warm welcome to all of you on this digital platform for another exciting session on no thrombosis workshop series on acute ischemic stroke. It gives me immense pleasure to welcome our host director for today's session, who is Dr. N.R. Richaporia, sir. Sir is the director of the Neurology Department at Sahyadri Hospital, Nagar Road, Pune. Sir has been part of the first neuro ICU and neuro-intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India, has the credit of delivering more than 300 public lectures and workshops on stroke. He is member of Indian Stroke Association and has been the ex-president of the Society of Neurosciences, has been principal investigator for multiple multinational stroke trials, and has been awarded as a health icon by the Times of India Group. We welcome you, sir. Thank you for being on board.
Thank you. Thank you for the warm welcome.
Our moderator for today's session is Dr. Hanshu Rohatgi. Sir is consultant neurologist and professor of neurology at Sir Gangaram Hospital, New Delhi. Sir is the secretary at the Delhi Neurological Association, the joint secretary at the Association of Neurologists in Clinical Research. Sir has been the principal investigator for multiple trials and has the credit of 47 publications in various reputed national and international journals. Our moderator for today's session is Dr. Meenakshi Sundaram, sir. Sir is senior consultant neurologist at the Apollo Hospital, Madurai. Sir has got the credit of delivering papers at various prestigious national and international forums and has an experience of more than 20 years in neurology. Sir is the editor of the South Asian edition of the book Practical Neurology and has contributed to many books on neurology. So we welcome you today. Thank you for being on board.
Thank you, madam.
We have three eminent speakers today who will be delivering three case presentations. So the first speaker is Dr. Sitaram Bharat. Sir is consultant neurovascular interventional radiologist at Gitanjali Medical College and Hospital, Udaipur. He has an experience of over 10 years in interventional radiology. He is a life member of Society of Therapeutic Neurointervention and has publications in various national and international journals. He is the principal investigator of various international trials and is peer reviewer for Journal of Clinical Interventional Radiology, Curious. We welcome you, sir. Thank you for being on board.
Thank you.
My next speaker is Dr. Sadiq Pathan. Sir is consultant neurologist at Sahyadri Multi-Speciality Hospital, Pune. Is a life member of Indian Academy of Neurology, Indian Stroke Association, and has credit of multiple national publications in national and international journals. We welcome you, sir.
Thank you. Thank you.
Our third speaker is Dr. Abhijit Sawant. Sir is consultant and HOD of the Emergency Department at Medicover Hospital, Navi Mumbai. Sir has been associated with the Emergency Department at Kokila Bain, Dhirubhai, and is consultant and department in charge at Reliance Hospital, Koparkharani. We welcome you, sir. Thank you for being on board. Now, without much ado, I would like to hand over the session to Dr. Richaporia, sir.
Thank you, Dr. Namra. It gives me great pleasure. Now, we've been conducting this no thrombosis program for the last 1.5 years, and I must say that there is a lot to learn. I've learned a lot of very interesting cases, and we've had extensive discussions. And I'm sure it will benefit all the speakers and the audience to join this forum. And I am very, very happy to welcome Dr. SMS, Dr. Meenakshi Sundaram. He's from Madurai. He's a very dear friend of mine and extremely good neurologist and I think he's done wonderful work in stroke, and it'll be a pleasure to listen to him also. So, welcome, Dr. Meenakshi Sundaram. How is everything in Madurai?
Namaste, sir. Fine, sir. Very fine, sir.
Yeah. I just came to know that, largest producer of jasmine flowers is Madurai.
Yes.
That's
Yes.
true?
Yes.
And
Yes,
they
sir.
make jasmine scent,
It's
and it is
exported
sent all
everywhere,
over the
sir.
world.
Yeah.
And it is
Yes,
sent
it's sent
to
all over the
France,
world.
and they sell it for hundreds of dollars per gram.
Sir.
So
Yeah.
Madurai is famous for so many things. Most of all, it is famous for Dr. SMS. But
Sir, thank you, sir.
and secondly, it's famous for the Meenakshi temple. But first, it's famous for Dr. SMS.
Sir, pulling my
So,
leg. Sir.
so welcome all of you. Welcome, Dr. Sadiq. Welcome, Dr. Abhijit Sawant, and welcome, Dr. Sitaram Bharat. Who's starting first, Namra?
Sir, Dr. Sadiq Pathan, sir.
Sadiq, are you ready? Are you on the phone? Your sound.
I'm ready, sir. I'm not been given the option to share yet for the files. So I was just speaking with this one to allow me the access to share my file.
Yeah. Namra, do you have Dr. Sadiq's slides?
it is intra-arterial near the ICA bifurcation and measured around 4 to 4 mm. I would like to show the image. On right, common carotid injection, you can see there is a two pseudoaneurysm formation. The medial one is more larger than the lateral one, actually. So that was dicey. If the metal entered here, why the aneurysm is more on the medial part. On ICA, as you can see, the MCA looks completely, M1 segment looks occluded. There's sluggish flow even in the A1 segment of the ACA, but retrogradely from the other side, the A2 and A3 branches were filling up. And the collaterals also of distal collaterals also of the MCA were filling up. So we were faced with various issues whether to intervene it or not. Given the scenario, there were other issue was that the anterior choroidal artery was also very closely arising. So we decided aspiration could be deferred because the MCA tissue had already infarcted since the patient had presented late to us, 18 hours, and it was a very sharp metal size, 4.4 mm. There could be risk of while removing it intravascularly, it may cause more harm rather than benefit. Secondary recanalization could cause hemorrhagic transformation. Being neurologists, we always think do no harm. So, I mean, that was a motive. We just waited to see if we could think anything more we could offer him. We took multiple neurosurgical opinions from seniors as well. And majority were, to conserve and see. Because they were of the opinion we'll just let it be because the collaterals are good, it would cause him more harm. But hence we decided to keep the patient just on antiplatelets and closely watch if there is any common carotid pseudoaneurysm formation later on. His routine labs, his ECG, 2D cover-normal. After admission, patient had very severe headache. Day and night he was with headache. More than him, the patient's relatives were very panicky because of his headache, and that persisted for 5 days. In spite of all analgesics, the headaches persisted. We even repeated a CT angio, and there were good collaterals. So we thought we'll still conserve and see. But secondary issues were we were worried about secondary infection since it was an outside metal piece. We had sent his blood cultures, though his CRP and lab parameters initially were normal, but the blood cultures grew Streptococcus viridans. Which was and this was the sensitivity. Streptococcus viridans coming, and then patient later on started having fever. So an ID infectious disease consultation was taken. Patient was we contemplated to have infective end arthritis, and the protocol was sort of treating it as with 6 weeks of vancomycin, as we do with prosthetic wall endocarditis. The decision was to keep him on vancomycin for 6 weeks. And after a few days, the patient's this fever settled down. His CRP headache had completely gone. In 2 weeks, as in till today, his NIHS is improving. In fact, this was till yesterday. His NIHS was 6. Today he started even. It has improved even up to 5. His upper limb, his headache is totally gone. His facial weakness has there's just mild facial lag. There are no visual defects now, visual field defects. His upper limb, he lifts above gravity. He has started walking. Lower limb power has returned. He requires one hand support of his dad, but today he could walk a short distance also. Uh, so this was the case. The reason for discussing was an unusual presentation, and we were really we didn't know, since literature doesn't did not have such cases. We really didn't know what to do, whether to go endovascularly, whether to surgically excise it. But I think we are just following up and trying to go up as the case proceeds, as the things are going on. I would like to know people's opinion also. What I think I've consulted Chapure sir also. Sir, what do you feel also?
Yeah, we'll ask Dr. Anshu.
Sir, this is very, very unusual. I think this is such an unusual case that you will not find anything in the literature. I think you have to go by your own common sense and what your colleagues have advised you. And I think he is improving. The patient is improving. So I think this is something which is worth publishing, because it is so unusual that it is definitely worth publishing. So thought
So
about it.
So, Dr. Sadiq, it presented at 18 hours to you, right?
Yes, sir. Yes, sir.
That is actually quite late for intervention, but I have removed metallic foreign bodies from MCA. It can be caught with a solitaire, like you just open little bit solitaire, push it forward so it will grab, and
Yeah.
then, but of course, 18 hours for a boy, no guidelines with us. So
Yeah, no guidelines. And the collaterals were good. So that's why we, even late intervention, already the infarcted tissue we could see, the collaterals were good. So that's why we decided we may do more harm rather than salvage the tissue. So that's the reason.
absolutely.
I think
So
another consideration was that, it was a very sharp object.
Yeah, sure.
So, when extracting it, it could damage the artery even further.
Yes, sir. Yes, sir.
So that was also a consideration. Isn't that, Sadiq?
Yes, sir. Yes, sir.
Because it was sharp, so when engulfing it with solitaire or, sucking it out with a penumbra or whatever, it could have damaged the vessel more, and, it could have led to bleeding, catastrophic bleeding. So therefore, I think the decision was correct. SMS, what do you think?
Yes, sir. Perfect, sir. I think you showed that case also to us. There are
Yeah.
a couple of things I would like to ask you, sir. First is that aneurysm which you showed. Kindly teach us what is that about. And the second is about the infective endocarditis part. How did it come in? How did it change the management and all those things, sir?
So what about the aneurysm?
Aneurysm will be
Please.
watched. Currently, he is good. The aneurysm has not increased. Clinically, we've been seeing him. Due to affordability issues, he'll be discharged today. He'll be taking the vancomycin at his native place, but he'll be in close contact. We'll be following up with his aneurysm also to see. Currently, it's quite small, and he is very he is very asymptomatic with that. I'm just worried after 6 weeks, if later on also we'll be asking him to keep that infective endocarditis prophylaxis, if for any dental extraction, any other thing, as we go for prosthetic valves. So since it's a foreign body in his brain, definitely he'll be prone. I mean, time only is going to tell if he again develops infection.
I think if he develops infection again, see, when there's a foreign body, antibiotics alone are not effective enough. So just now he's fine, but you may have to do a surgical removals, not endovascular, surgical removal of the vessel, doing an arteriotomy. So you'll need a really skillful person to do it. because if the infection continues, then you will have to do that.
Yeah.
But
Yeah.
if the infection is not there, I think just let it be.
True.
Because otherwise, doing such a major procedure, you may damage the vessel even more. And luckily, these young people, even with large MCA infarcts, they do reasonably well, I mean, there is so much plasticity for a 10-year-old that, of course, they may have a little faciobrachial weakness. It's on the left side, no? Right side of the brain. It's on the
left
right side?
Right side of the brain and left
Right side.
facial
Right side
left
of
hemiparesis,
yeah.
no?
Left
So, yeah, they could have, he could have some cognitive impairment because of the large MCA infarct. But with the brain plasticity and all, these young people, they can lead a fairly normal life, I think. And already he's walking, with support, and NIHS has come down to 5. So over the next 3 months, I think his modified ranking scale should come down to 1 or 2.
Hopefully.
Maybe there will be little hand weakness and little dexterity issues. But if he doesn't get fever again, then I think I'll just let it be. That is my opinion. If he gets fever, I think then we'll have to open up that vessel and take that risk. SMS, what's your view?
Yes, sir. Yes, the same thing. When you looked at the angio which you showed, it was a fantastic angio because all in the middle was hypodense and all around the blood vessels were just their cortical vessels. Everything was actually perfusing all around the infarcted area. That's the reason why probably it came better. And I don't think we can just call it collateral because it is natural collaterals which has been happening because this guy, no way would have got any ischemic lesions in the past. Should be natural collaterals existing for him. That's why he has become better. What is your guideline for that aneurysm? So what are you going to do about that neck aneurysm? You will just wait and watch. Would you
Nothing
do an
to be done,
angio
I
again
think.
later, or you will just see?
Nothing to be done.
No, will
I
you
don't
be
think
repeating an angio to see the
worry too
aneurysm?
much. Unless it is expanding and, pressing on some, hypoglossal nerve or something. Otherwise, just let it be. Because the aneurysm means it has just, that's the point of penetration. And, that vessel wall has been weakened there. Because you'll see it at 2 places, So it's penetrated and probably hit across also and then gone up.
Yeah.
But I feel this is a case worth presenting to some international journal because the artery to artery embolism of a foreign body.
Very unusual.
Dr. Bharat, what was your case of foreign body? You said you extracted it.
Yeah, so in our case, actually, cardiology colleagues, they were doing a ASD repair. So the metal marker which is there on top of their sheath
Okay,
had broken down and gone. Yeah.
Okay.
So it was also metal.
But this is a totally unusual case.
This is amazing.
Amazing.
Yeah.
Sadiq, you must present this. I mean, you must publish this case.
Worth publishing.
Worth publishing.
Yeah, and the other metallic sheets, they will not infect. I mean, they are already. This is an outside foreign one.
Yeah, this is an external artery to artery embolus.
This is one maybe in a millennia this will happen.
What?
Once in a millennia, this kind of thing will happen.
You never see. That's why I told Sadiq, you must present this case. And though there is no tenective place given.
My only thing is, had his sir, what do you feel? Had his father not compressed it?
See, he was bleeding, no.
Oh.
So you have to.
The compression would have displaced it.
He would have died here with all that bleeding.
Maybe.
Because if it's penetrated the carotid, it will bleed like a tap. And the bleeding will hit the ceiling on top, The pressure is so much that he had to press it. I mean, the reaction of anyone when you see bleeding is to press it, no? Who would think that it will go into the carotid and then into the MCA and produce a stroke? Nobody in their wildest imagination would think of it. So first reaction would be to stop the bleeding. Okay, great. It's really
phenomenal case, sir. Extraordinary
case. Huh?
Extraordinary case, sir.
Yeah, yeah.
I mean, wouldn't imagine this really.
Yeah, Sadiq. Thank you so much, Sadiq.
Thank you.
Well
Thank you.
presented also, and very well discussed, I must say.
Thank you.
Yeah. So shall we go on to the next case?
Yes, yes.
Yes, sir.
Yeah. Who's going? Namra, who's going?
Abhijit, will you, Dr. Abhijit, sir, will you take the next case?
Yes, sure. Let me just share the screen. Yes, good evening, everyone. Am I audible?
Yes.
Yes. I will be presenting a very simple case. I'm Dr. Abhijit. I'm emergency physician. Around a year. Yes, got it? Yeah. Yeah. So I will be presenting a very simple case that we had around a year back. We had a 63 years old male patient who presented with bilateral upper and lower limb weakness and dysarthria. All this started around 60 minutes back. There was no obvious seizure-like activity noted by any of the relatives. Patient initially when presented was slightly confused when he came to our ER. So whenever we have a suspected stroke patient, first thing we go ahead with ABCs, vital parameters. He was slightly tachycardic, pressures were okay, 130 by 84. Sugars mainly, HGT was 122 mg per DL, not minute. HGT was 122. So he was definitely not a hypoglycemic patient. On clinical examination, his GCS had slightly improved. It had become from 14 by 15 to 15 by 15. Pupils were bilaterally equal, reacting to light, and NHS was 16. He had weakness in his both right upper limb and the left limb as well. The other parameters.
Right upper limb and left upper limb.
The left upper limb and right upper limb as well. Even the lower limbs, bilateral limbs were involved. So right side was involved more as compared to the left side.
So he was quadriparetic.
He was almost quadriparetic. He was moving his limbs, but with great difficulty. He was almost quadriparetic. So we had a suspicion whether he had something like seizure episode or something, but then we came to know that he had a past medical history. He had a history of seizure as well, and he had left hemiparesis 2 years back, for which he required right MCA mechanical thrombectomy. After which patient had improved significantly and his MRS was just 1. He used to do all his routine activities on his own. So we had to activate our code stroke, and immediately we ended up shifting the patient for MR angiography, brain and neck plane. So this is in my institute, we prefer MRI scans over CT scan. In case if there's any patient in the MRI department, we quickly offload that patient and take the stroke patient on first priority. So for him, fortunately, we were able to shift him from the ER to MRI within 8 minutes of the patient's arrival. And these were the initial MRI findings. So the findings that we got were within 16 minutes, we were able to receive the angio part as well. We did a diffusion, a flare, followed by an angio. And we can obviously see an occlusion over here. So immediately the relatives were counseled. Luckily for us, it was very easy to counsel the relatives as patient had already had a history of stroke, and relatives were aware of the treatment for ischemic stroke. So the decision from the relatives was also quicker. They gave us consent for thrombolysis immediately, and we were able to thrombolize the patient with injection tenecteplase of 14 mg. So what we did was, after this angio itself, we immediately thrombolized the patient on the MRI table itself. And followed by that, the other MRI sequences were done. And at the end of those, after almost 12 minutes of thrombolysis, we were able to do a recheck angio for him. And you can obviously see the blood vessels. There was a good flow, and there was obviously a good thrombolysis in this case. So patient on presentation, he had an NHS of 16, and after thrombolysis, after 12 minutes, when we were able to take the patient out of the MRI department, we rechecked his NHS, it was 3. Patient was walking, talking, he was able to get down from the MRI table and walk out of the MRI department. He was speaking, he spoke with us, he thanked us for the prompt intervention. So his NHS had definitely improved after this quick thrombolysis. So what we follow is, we have a stroke team which comprises of neurologists, neurosurgeons, intervention radiologists, emergency physicians, critical care physicians, and radiologists. So whenever we get a stroke patient, we immediately activate a code stroke, and all of the team members immediately receive a message. And so we are able to quickly take care of these patients in case the MRI and all. In case if the senior neurologist or critical emergency physicians are not available in the department, at least the radiologist sitting at home can immediately give us the report, and we can discuss and take a take a decision about whether the patient requires thrombolysis or patient has to be managed in any other way, whether the patient require intervention radiology, some mechanical thrombectomy, or anything else. So this is one of the stroke protocols that we follow. So one thing I would like to stress over here, I'm in emergency field since last 15 years. Earlier, I remember we used to thrombolize definitely with Actylase. But there was one difficulty that we used to have. We had to wait either till the MRI was over and then thrombolize, or give bolus of Actylase and then continue with the infusion. But for that, we required a very long PMO line and keep the infusion pump outside the MRI department. So it used to be very difficult. Plus, the monitoring used to be difficult in such cases. But definitely, tenecteplase has definitely helped us, because it has definitely helped to decrease the door to needle time. Here we are able to thrombolize the patient in the MRI department itself, and at the end of thrombolysis again, we can redo and angio sequence and check whether the vessels have opened up or not. So this patient was later on shifted to the ICU, monitored in the ICU for a couple of days. His ECG and all showed AFib. So he was started on dual antiplate. He was started on anticoagulants as well later on. And patient was discharged with NHS of 1 after 3 days of hospitalization. So this case particularly I wanted to present because it shows if definitely if we are able to pick it up and manage the patients quickly, patients improvement is we can definitely see the improvement of patients immediately. Patients are also happy. Thank you.
Yeah, this is the great advantage of early door to needle time. And everyone everyone stresses on this early door to needle time. This is a well-known fact that earlier you treat, the prognosis is better. And very clearly it is shown. And this is a case of VENI. VENI means very early neurological improvement. This occurs in about 15 to 20% of cases. And but what I'm surprised is, that he had a previous stroke. He was never diagnosed as AF before. He had a bypass, you said, no, previously?
He had an IHD and he has undergone PTCA.
PTCA.
Yes.
Okay.
Earlier
so,
also,
on follow-up, this many times I'm finding that even cardiologists are not picking up AF. And recurrent stroke in this thing is mostly, it is because of AF only and cardioembolic. So very, very often, even cardiologists are not picking up AF. We have to be very careful, especially with a cardiac history, picking up AF and anticoagulating them as primary prophylaxis. So now, of course, we have to give secondary prophylaxis, with preferably a NOAC. Which drug had we given for AF prophylaxis?
Later on, yes, he was started on NOACs itself.
Yeah, I think NOACs is the way to go. But I would implore, many cardiologists, many times I've seen this, that patients had AF. It is documented AF also. And they've been visiting the cardiologist, but people have not started on anticoagulants. So there is a big treatment gap in the use of anticoagulants in AF, not only with general physicians or with GPs, but also with cardiologists. So I think this is one big gap. And of course, you have done extremely well. Your door to needle time is excellent. And because of the excellence of your stroke pathway, you could help this patient. And, many times this is an LVO, but it appears like a distal M1 or M2. So very, very often on this forum also and in real life also, we have seen that tenecteplase seems to be better in large vessel occlusion rather than actylase. It has an edge. This has been shown in some trials also. It's not only anecdotal. That LVO's tenecteplase is better, but you should use, I think now very standard is you should use 0.25 mg per kg. Yeah, though on the product insert it is still 0.2 mg, but all over the world now for LVO especially, we are using 0.25 mg per kilogram. So maybe you could alter that a little bit. It makes a difference of about 3 to 4 mg of tenecteplase. So 0.25 is the way to go. Though it's not in the product insert, I know that. But I think that's become more or less standard all over the world. And, actylase is also good. It's not that, but you can give the bolus in the, you don't have to have a long line, You can give the bolus of actylase, shift the patient out of the MRI department and continue with a syringe pump actylase. You don't have to give the full thing for 1 hour in the MRI department. But certainly, tenecteplase is more convenient, easier to administer, and it has been found that LVOs, with the Extend 1A trial, that LVOs, the chances of opening up is about, I think, if I'm not wrong, 29%. And with actylase, it was 17% at 1 hour. So it has definitely an edge over actylase, not only in ease of administration, which it has, but also in the conversion of opening up of LVOs. So many times we have seen that otherwise, these patients would go for mechanical thrombectomy, and we can save tremendous amount of resources of the patient by tenecteplase. Umpteen times we have seen on this forum and in life that, these cases look typical of, the interventionists are itching, to put in a catheter inside. But giving tenecteplase many times, the official figures are 30 to 35%. But as you go more and more distal, M2, M3, it goes up to 50%. For ICA, distal ICA occlusion, the results with IVT are not good. They are only about 8 to 10%. So therefore, certainly for distal ICA, you would use mechanical thrombectomy. But as you go little more distal and, the clot size becomes lesser and lesser, in your MRI, you could have measured the clot size, clot length, clot length. If the clot length is less than 8 millimeters, more chance that it was open up with IVT. If it is more than 8 millimeters in length, then mechanical thrombectomy may be necessary. But many times we have seen also, the advantage of CT angio over MRI is that you can see porosity of the clot. You can see, whether the clot is porous or not, whether the dye is going in or not. So we in our center are using CT angio much more than MRI for acute cases in the first 4.5 hours. If it is later, yes, we use MRI, but the level 1A evidence is CT angio. It can tell you collaterals, which MRI can't tell you. It can tell you porosity of the clot. It can tell you length of the clot. And very easily you can give the thrombolytic agent in the CT console itself. So these are the advantages of CT angio. But yes, I know many people, especially in Mumbai, are preferring MRI. I have nothing against MRI, but I find that it is a little more cumbersome, and there are some disadvantages also. So, Dr. Anshu, would you like to say something else?
I think the two things are very important. I think this case has shown is that door to needle time is very, very important, because I think that's why we had a very good response. The second thing, they have a very good protocol, and we also have this similar kind of protocol, which is known as we have made a code gray. So the moment we have a stroke patient, the person in the casualty activates the code, and everybody, like we have a similar team, everybody gets activated. And we are using an MR protocol now. We have been using it for now number of years, so we are more comfortable with an MR. Of course, when we find it difficult to do an MR, we do a CT angio, of course. But we do an MR protocol, and we have seen number of times patients waiting for a thrombectomy. They can't afford it. The cost, of course, is prohibitive in our country. Asking anybody in the dead of the night to bring about 5 to 6 lakhs of rupees for a procedure is a very, very difficult thing. And we have seen patients who have said that they don't have the money and we can't get it. Then we have given tenecteplase, and we have got some of these patients have done really well. So I think what Dr. Iksepuria said is absolutely true, that some of these patients may do well. And I think only the distal ICA, where I think the clot volume may be a little larger, maybe we will not be able to use it. But I think the extend IA TNK really showed that tenecteplase for large vessel occlusion is at least, I think it's in the guidelines also. The AHA guidelines also say that if you have a LBO, then tenecteplase is better than Actelyze. So I think this is important.
Yes, Dr. SMS.
Thank you very much, sir. Nice case, sir. Very nice. And especially when you showed the angio before and after, no, it gives a nice feeling to see the vessel blocked and then it is open, give a nice feeling. As sir said, nowadays we have shifted to completely 0.25 mg. After the ACT data, you can read that. After that, everybody is now using only 0.25. Even in the data which sir quoted for us, which is the extend IATA TNK trial, they are also use only 0.25, I think. And the benefit is that in LVOs open up, that's what we actually want. We want less number of patients to go for mechanical thrombectomy when they have a large vessel. And that is what is achieved. That is a Bruce Campbell data you can read. Around 20% for tenecteplase, vis-a-vis only 9% for alteplase in those large vessel occlusion. That means a big boon for us. Almost 10% people have to go less often for mechanical thrombectomy than not. That's the one thing. Only thing which I want to clarify was the clinical findings were not very correlative. Any comment on that? I want to learn from sir also. The clinical findings were not very fitting into this. The NIHSS as well as the weakness part, which you said, no, I didn't get it really, sir, actually.
Yeah, I got confused in the beginning when Abhijit was presenting. I thought, it was a basilar artery, this thing, because it was quadriparetic. But what I'm thinking now is that he had that previous stroke, and maybe there was some the brain got hypoperfused, and therefore he looked quadriparetic, but actually he was not quadriparetic. So that is what I thought as he was presenting. But this Veni, it is magic, and these patients, Abhijit, will bless you forever.
Yeah.
He came paralyzed and he came out walking. So this is also called the Lazarus phenomenon. Lazarus, this is a story of Jesus, and this Lazarus was dead, and then Jesus came at his tomb and visited Lazarus, and Lazarus awoke from the dead. So it was a miracle. So I don't know whether these miracles occur, but these are miracles, This fellow has come with NIHs of 16, and within minutes his NIHs become 3 and 2 and 1. So it is a miracle. So this is the miracle of stroke thrombolysis. And these patients, they will send you biryani, and they will send you whiskey bottles, and they will send you God knows what else on Diwali. So, and they will become friends of yours for life. So, it's so satisfying. This like magic, they improve. Like magic, once that thrombus dissolves, or even after mechanical thrombectomy, magic here. On the cath lab table, the fellow starts moving. He was totally grade 0, and he becomes grade 5 on the cath lab table after removing that clot. So these are the real wonders of stroke thrombolysis and mechanical thrombectomy. And this is where I think we must, advertise these facts. ऐसा भी होता है, and patients improve so well and they can lead normal lives again. Otherwise they would have been bedridden. This chap would have been bedridden or something like that. So this is the wonder of stroke thrombolysis and mechanical thrombectomy. What do you think, Dr. Bharat?
Yes, sir. This Veni happens rarely, but if it happens, you can boast about like for a long time.
You put it in the newspaper and you must boast about it. It is not advertising.
I have an experience where one patient we did thrombectomy, and reluctantly I just asked, "Babuji, kya naam hai aapka?" And he spoke his name.
Yeah. So it's so thrilling. It's not satisfying. It's thrilling.
Yeah, it's thrilling.
It's thrilling.
Yeah. And that thrill is what keeps us going,
Exactly.
It should happen more often.
Yeah. We want it to happen every single time. But these damn patients don't come in time now.
Yeah.
Okay. So many important things, Abhijit, you have elucidated in your presentation. The value of stroke code, the value of early treatment, the value of the IVT with tenecteplase in LVOs, the concept of Veni and Lazarus's phenomenon, and the use of NOACs in AF, which should be used as primary prophylaxis rather than after a stroke. So many points. You said it's a simple case, but see how many points there are.
Yes.
And, so much to learn for everyone from all these things. Yeah, thank you, Dr. Abhijit.
Sir.
Yeah, SMS, you want to conclude?
Yes, sir. The previous one was also on the left side, right, sir?
Huh?
Both of them were on the same side. Where is the side? The previous stroke and present stroke.
Different side.
It was on the opposite side. The previous stroke was on the opposite side.
And this one was the other side.
Yes.
First was right MCA and second is left MCA.
Left MCA.
I think they were mirror images of each other. If you see the MR,
yes,
they were mirror images of each other.
Cardiac. So that all the more tells us that you have to get for the source either
it's
from the
cardioembolic. It's
or
different.
From the aortic arch.
Correct. It has to be cardioembolic. It has to be cardioembolic because it's on two different sides and MCA only. So it goes into the MCA only. Okay.
And
thank you, Dr. Abhijit.
Prolonged
Wonderful.
recording.
Yes, sir.
Prolonged recording holder is required in most people. And today the minimum criteria is at least 2 weeks. Now, fortunately,
Of what?
chips are
Of what?
available for
Sir, Holter for 2 weeks.
Holter.
And
But here
minimum recording is
here the monitor only showed AF here.
Yes.
yeah.
for him,
Monitor
So
showed
in
no
another
AF
case,
in the ICU.
yes, this time,
even
luckily for him, the monitor showed AF.
Yeah.
But in the previous one, he had undergone Holter monitoring for 24 hours, but it was normal.
See, you have to do
that's what
prolonged monitoring.
today the
As you
recommendation
do
is
more
2 weeks
prolonged
minimum.
monitoring, your yield increases. I mean, it stands to reason. So, people make the mistake, Arey, Holter was normal. So how can it be F? Arey, who said? You've done the Holter only for 24 hours. The longer you do it, the more chance that you will pick up AF. So just 24-hour Holter and there is no AF is the wrong concept. So we need to change that concept. So do it if you are strongly suspecting once on right side, once on left side, different vessels. Vessels look basically normal. He's had a heart issue in the past. He's elderly. All point to atrial fibrillation. Yes, Dr. Sitaram, I think we can take the case.
One more comment, sir.
Yeah.
Probably
Sorry.
the right MCA, when it was infarcted, there were some good collaterals going from the left side, I think. That's why when the left side got affected, probably there are quadriparesis like phenomenon. How good is this thinking, sir? Is it possible?
I don't know.
Is it possible that in plasticity, some of his right side work was taken up by the left side?
Left, that's what I'm saying.
Yes,
like a
that is what
diastasis,
we
or by the left was
suspected.
doing.
I am a great proponent of the stunned brain phenomena, you get or you get diastasis, one side is affected, other side gets hypoperfused, or even cerebellum on the opposite side gets hypoperfused. And like how you get stunned myocardium, why can't you get stunned cerebral?
Yes,
and then you open it up and then everything like magic just improves. I mean, there are so many unknown things. I don't know whether we can answer it. Unless you do some, functional MRI or something like that.
So as Dr. Sitaram sir was saying, probably the right brain was actually getting good perfusion from the left side in this patient because of the previous stroke. The working was coming from the opposite side. Probably that also got
we are
affected.
seeing good vessels on the right side, SMS.
Right side also.
Yeah, we are seeing good vessels.
Okay, sir.
Yeah.
Okay.
Yeah, Dr. Sitaram.
Yeah, so I'll go ahead, sir. I'll share my screen. Is it visible?
It's unmute. The first one is fine with me, second one is not.
Is it visible, sir?
Yes.
Yeah. So I didn't know how many cases I had to present, so I selected a couple of them. But
I think you take one only.
So I will take,
because see, we are already at 9:30.
already behind time. So I will just show one case which is, I feel,
take your best case.
Best case, yeah. I'll just skip through them.
And of course, you can come back again.
No, so we will start.
Normally, we have only 2 cases, but this time we had 3. So, we are running short of time.
So I'll only present this one case, which is.
And maybe next time you can present the others.
Absolutely, sir. No problem. So this is a 59-year-old male. He initially had visual difficulty for 12 hours. And then he kind of neglected it. And then finally he became unconscious. When he came to our hospital, he was unconscious for 3 hours. And then he was intubated in ER. He was already taking double antiplatelet for his cardiac condition. So initially a CT scan was done, which shows that there is this PCA territory infarct over here.
Just put slideshow.
Is it not on slideshow?
No.
I'll stop share and then I'll go again. Is it on now? Is it on slide share?
No.
Still not there. Oops.
Okay, let it be.
Okay, sir.
Only thing is it's small,
It is small, yeah. So why is it happening? So I'll just go through. No, just let me take. So is it now on full screen? Yes, sir. Okay.
Yeah.
So as we can see, there is already a established infarct over here in the PCA territory, and the basilar is hypertense. Okay. So because we couldn't explain his unconsciousness, we had to do MRI, and we found that there are some early changes here in the brainstem. This is already established infarct. The basilar is occluded. Established infarct over here. So we had to take the patient for thrombectomy because he was
Just
already
show the CT scan again.
Yes, sir. This is the CT. So hyperdense basilar over here.
There is a dense basilar sign.
Dense basilar over here.
Yeah. There is a basilar dot sign. Whenever the patient is unconscious, you should look for this sign.
Yes, sir.
So this is typical of basilar artery occlusion. This dense basilar sign or basilar dot sign.
Yes, sir.
Yeah.
And already infarct was there over here.
Yeah,
So, but whenever there is a posterior circulation stroke, we have to see at the posterior fossa aspect, which is through MRI, because if the brainstem is already infarcted, then usually the intervention becomes futile. But here the brainstem doesn't look that bad, though there are some early changes here, but it doesn't look that bad. So we decided to go ahead for intervention. So we did the angiogram from the left side, and we thought probably it is occluded here, but to our surprise, this was ending in pica. So we had to come on the left side and see what is happening on the left side. And if you see on the left side, when I inject here, I see that via these collaterals, the vertebral is reforming in the neck, but I don't see any obvious origin over here. So probably there was a tight stenosis or maybe a chronic CTO, which is a possibility. But that is where the treatment decision comes forward, that we have to treat this patient, because otherwise without treatment, this patient probably will not do well. So what we have done is we somehow managed to find this small teat over here, and this is what looks like a vertebral artery origin, and we had to cross the wire. We had to take hard wire, make a loop and go. It was kind of like a subintimal angioplasty. So we did do the angioplasty, went up, and with a solitaire we managed to remove the clot. This artery also is looking very badly diseased, and this is the artery here. But luckily we could achieve TK3 flow in this patient, and because he was already on double antiplatelet, this dissection we stented it. And if you see at the end of the procedure, this patient has good antegrade circulation all the way up to the brain. So this is a stroke which was progressing. So we can say that stroke in evolution was first he had only posterior circulation PCA infarction, and then later on he developed basilar thrombosis. So this is the CT next day. Again, if you see, I want to show this CT for one interesting thing. The area which was infarcted has now got this contrast staining because of the breakage in the blood-brain barrier, and this is not a bleeding. This is a contrast stain in an infarcted area, and the brainstem looks fine, and the basilar now doesn't look dense. And this patient really did well. If you see, he was extubated on the next day, and this patient is able to lift his both hands, and he's come out of the quadriparesis. So these are few of the things, which sir was discussing, that keeps you going. And so to discuss, this patient had right VA ostium was probably chronically occluded, or it was tightly narrowed. So without the treatment, outcome would have been definitely been bad. So it was a motivation to try this rather aggressive strategy. And as the patient was already on double antiplatelet, stenting was an easy choice for me. Thank you, sir.
Yeah, very good, very good. See, without the procedure, he would have died.
Yes, sir.
Because, but I'm very happy to see the extremely good result. Did he have ptosis, by the way?
He had a little ptosis, sir. If you can
He had
see,
what?
He has a ptosis on this
Ptosis,
side.
huh?
Yeah.
Because I couldn't see his eyes properly. Yeah, because maybe the top of the basilar got involved. Top of the basilar got infarcted.
He had a third no pulse, because of midbrain involvement.
Yeah. But great result, I must say.
Yes, sir.
Could you get the Ryle's tube out?
Yeah, we could remove his Ryle's tube out. We kept it for some days, I think 5-6 days, but he did not have any symptoms of lower medullary involvement at all. So we could remove it. It was actually prophylactic to give him antiplatelet and all initially.
Yeah.
But then
lower medullary is probably spared because that pica is very open, no?
Pica is open, yeah.
Yeah. So this is mainly top of basilar type of syndrome because the PCA got involved.
Top of basilar, yes, sir.
Yeah.
So even if
yeah. So very well done, I must say. Very well done.
So if you see here, it is only top of basilar.
Yeah.
Pica is spared because one side is ending in pica is other not, pica is normal.
Yeah. So that's why his brainstem, his medulla got saved.
Yes, sir.
And maybe midbrain was involved. That's why he was drowsy. And he's got ptosis and ophthalmoplegia. But good, I would say, guts. You need guts and glory. To get glory, you need guts. So extremely good. Well done. SMS and Anshu?
Amazing results, sir, really. Amazing. And, really, the posterior circulation strokes can go either way. There are patients whom we have gone in and we have opened them, and still they have progressed and we have lost them. As sir was saying, it's an amazing work, especially to see the patient having such a gratifying result, really. Phenomenal, sir. Congratulations, really. How many hours post-stroke we got it?
So he had stroke in evolution. So at 12 hours, he had only PCA infarction, and later on for 3 hours he was unconscious. So we probably see that it was early basilar stroke. Yeah. Early basilar, but
something similar to this botch data, Chinese botch data, 6 to 24 hours window.
But basilar will give you amazing more nightmares than glorified results. Most of the time, they are saddening to us. That is my experience doing this basilar treatment, and sometimes when
they are unconscious, they will have 100 questions to ask. The first thing is that whether his consciousness will improve or not. That will be the first question. And then management of not only the stroke part, ventilation, everything is going to be extraordinary cost.
Yes, sir. Yes,
the cost will be really baffling.
And most of the time, these
patients, thrombectomy, mechanical ventilation, staying in ICU, and then the patient's expecting magic results. But you have been able to provide everything, I think. I mean, not even on a ventilator, just sitting there, really amazing results.
Otherwise, if they end up in locked-in syndrome with tracheostomy, those patients will never leave you. They keep
these basilars, they don't survive also. So this is a very good result, I must say.
What is the visual deficit now, sir?
He has hemianopia, because that part was already infarcted when he came.
Yeah, he'll have hemianopia. Okay.
So tell him not to drive, that's only.
Yeah.
He's not driving.
Anshu?
Yeah.
Anshu's probably left. Okay. SMS, anything more you want to say? Or shall we wind up? Yeah. So well done, Dr. Sitaram. Very, very nice case.
Listening to
otherwise, as I said, guts and glory both have to go together, and very, very gratifying. So I hand it over back to Dr. Namra for her closing remarks. Dr. Namra.
Thank you so much. Thank you very much for providing time for this meeting, sir. And we are extremely grateful to you for the same. We got wonderful clinical insights from our expert speakers today. I would like to thank Dr. Meenakshi Sundaram, sir, for your valuable insights. I would also like to thank Dr. Abhijit Sawant, sir, Dr. Sadiq Pathan, sir, and Dr. Sadiq Pathan, sir. And thank you,
Sitaram
Bharat. Thank you. Thank you so much, Dr. Sitaram Bharat, sir. Thank you for providing time for this meeting. And today we have 400 plus attendees.
400 and how many?
410.
Very good. So, Sadiq, 410 people have seen your case, huh?
Wow.
And Sitaram also.
Many more has to see, sir. He has to publish it.
वो तो देखेंगे यार.
Yeah, वो देखेंगे.
वो देखेंगे. SMS, thank you for all your insights. As usual,
thank you very much, sir. Thank you.
Always smiling. This Meenakshi Sundaram, no, he is always smiling.
Thank you, sir.
Okay, chalo. All the best. Good night.
Good night, sir.
Thank you so
Good
much.
night, sir. Good night. Good night.